Welcome to the deep dive. You've sent us some really interesting material this time, focusing on muscarinic acetylcholine receptors.
Yeah, these tiny little things on our cell.
Exactly. And acetylcholine itself, the body's own messenger, plus a whole range of drugs that either, mimic it or block it.
Right, drugs that either push the gate open or hold it shut, essentially.
So our mission, like always, is to sift through this and pull out the really crucial, the most fascinating bits for you.
And it's such a core system we're talking about. I mean, these receptors, they're involved in so many automatic things. Heartbeat, focusing your eyes, digestion.
Right. We're going to explore how this whole acetylcholine signaling pathway works and how manipulating it with the drugs can have such big effects.
Absolutely. All through the body.
Now, one thing that really jumped out is this challenge of selectivity. It seems fascinating.
It really is.
You've got these receptors, they do different jobs, but the main place where the messenger binds the docking station, it's remarkably similar across the different types.
How they can serve, yes.
Yet, scientists are actually making progress in creating drugs that can target specific subtypes. So we want to get into why that's been so hard and, what clever approaches they're using now.
Sounds like a good plan.
Okay, so where do we begin? Let's start with the main player, acetylcholine, or AH, the key itself.
Right, so AKH. It works mainly through these muscarinic receptors. And you find these concentrated on effector cells in the autonomic nervous system.
The automatic part.
Exactly, the part running things in the background. Particularly the parasympathetic side, the rest and digest network.
Okay.
But they're not just there. You also find them in autonomic ganglia, some cells that aren't directly connected to nerves, like the endothelium, the lining inside your blood vessels, and really importantly, in the brain.
Ah, the central nervous system, too.
Yes, in key spots like the hippocampus, the cortex, the thalamus, places involved in memory, thinking, processing information.
So, okay, if AH is everywhere and does so much vital stuff, why don't we just use a patch as a drug? Seems like it would be useful.
That's a really logical question. But the big problem is, if you just injected ACH into someone's bloodstream, its effects would be, everywhere. Too diffuse.
Hitting all those receptors at once.
Exactly. Imagine the chaos. Plus, ACH gets broken down incredibly quickly by enzymes in the body. It's like a message that disappears almost instantly after it's delivered.
Ah, okay. Not practical, then.
Not for systemic use, no. It just doesn't stick around long enough to target anything specific.
So when we talk about muscarinic actions, what we really mean is copying what SE does at those specific autonomic effector sites, kind of like boosting the parasympathetic system in those spots.
Precisely. And these actions happen through 5 different subtypes of muscarinic receptors. They're just labeled M1 through M5.
5 different versions.
Think of them as slightly different models of the same basic lock. They all recognize ACE, but they trigger different signals inside the cell once they're activated.
Okay, so what happens inside? What are those different signals?
Well, broadly speaking, M1, M3, and M5 receptors tend to work through something called the GQ protein pathway.
GQ.
When ACE binds, it flips a switch, activates an enzyme called phospholipase C, or PLC. This chops up certain molecules in the cell membrane, making IP3 and diacylglycerol.
Right, I remember those.
And that ultimately leads to a release of calcium ions inside the cell. Calcium then triggers all sorts of downstream effects.
Okay, so M1, M3, M5 use GQ, boost calcium. What about the others, M2 and M4?
Right, M2 and M4 are usually linked to G or GO proteins. They generally do the opposite.
The brakes.
Kind of, yeah. They tend to inhibit an enzyme called adenylyl cyclase, which lowers the levels of another messenger, cyclic AMP. They can also directly affect ion channels in the cell membrane, changing how ions flow in or out.
Different receptors, different internal effects. But you mentioned earlier, it's tough to make drugs that only hit one subtype. Why is that so hard if they trigger different signals? They all bind HU.
Yeah, the core problem is that main binding site. The technical term is the orthosteric site. That's the pocket where HE itself docks.
The main keyhole.
Exactly. And studies, like using X-ray crystallography, have shown this pocket is incredibly similar in shape and chemical nature across all 5 subtypes, M1 through M5. It's deep inside the receptor, made of amino acids that haven't changed much over evolution. They're highly conserved.
Right.
So trying to make a drug that fits only one of those 5 almost identical keyholes is, really, really difficult.
That makes total sense. Like trying to pick one specific lock when 5 feel exactly the same. So how are scientists getting around this? You mentioned allosteric modulators.
Exactly. This is where the clever chemistry comes in.
Yeah.
Instead of aiming for that super conserved main keyhole, researchers are looking at other spots on the receptor.
Different docking sites.
Yeah, allosteric sites. Think of them like secondary control panels located somewhere else on the molecule. And the exciting part is, these allosteric sites tend to be in areas where the receptor structure does differ more between the M1, M2, M3, etc. subtypes.
Ah, so they're more unique to each subtype.
Generally, yes. So by designing molecules that bind to these unique spots, scientists can kind of indirectly influence how the main site, the orthosteric site, behaves.
So they're not blocking or activating the main AC site directly, but sort of tweaking its sensitivity?
Precisely. They can act like dimmer switches almost.
Yeah.
A positive allosteric modulator, a PAM, binds to its site and makes the receptor more responsive to I.
Makes it easier for AC to work.
Right, or makes the effect stronger or last longer.
Yeah.
Conversely, a negative allosteric modulator, a ANM, binds and makes it harder for AC to bind or dampens the response.
Okay.
And sometimes you even get molecules that bind to an allosteric site and activate the receptor all by themselves, that we usually call those allosteric agonists.
That's really smart. So targeting these more variable regions could lead to drugs with fewer side effects because they're more targeted.
That's the big hope, absolutely. It opens up possibilities for treating complex things, maybe CNS disorders like Alzheimer's or schizophrenia, where hitting just the right pathway is crucial. And we're getting really detailed pictures now showing how some of these PAMs bind right next to the X pocket, almost trapping AC there for longer.
Wow. And you also mentioned bitopic ligands. Sounds complicated.
It's a really elegant concept, actually. Bitopic ligands are like hybrid molecules. They're designed to latch on to both the main orthosteric site and a nearby allosteric site at the same time.
2 points of contact.
Exactly. By engaging both spots, they can achieve super high affinity, they bind really tightly, and also amazing selectivity for just one receptor subtype. It's like a key that fits the main lock perfectly, but also has an extra bit that only fits a specific feature on that lock.
That is sophisticated stuff. Okay, so we've got the receptors, how they work, the challenges in targeting them. Let's move on to what acetylcholine actually does in the body. We know it's not used systemically, but understanding its effects helps explain the drugs, right?
Absolutely essential. Let's start with the cardiovascular system, heart and blood vessels. ACE has several key actions here. It generally acts like a brake on the heart. It causes vasodilation, widening of blood vessels. It slows the heart rate. That's a negative chronotropic effect.
It slows it down.
It reduces how fast electrical signals travel through the AV node, the connection between the upper and lower heart chambers. That's negative dromotropic.
Yeah.
And it can weaken the heart's contraction force, especially in the atria, the upper chamber's negative inotropic effect.
So wait, if it widens blood vessels, causes vasodilation, why isn't it used for high blood pressure? Seems like it should lower it.
Well, it can lower blood pressure, transiently anyway. It does this by acting on M3 receptors on the endothelial cells, the lining of blood vessels. That makes them release nitric oxide, which relaxes the smooth muscle.
Okay.
But it's complex. Giving EAG intravenously often causes a quick drop in pressure. Yeah, but then the body can react with a reflex increase in heart rate, kind of counteracting the effect.
The body fights back.
And if the blood vessel lining is damaged, AC might actually cause vasoconstriction by hitting M3 receptors directly on the muscle cells. Plus, again, it gets broken down so fast, so it's not practical. But knowing these effects is crucial because lots of heart meds interact with this system.
Okay, that makes sense. What about breathing, lungs, and airways?
In the respiratory tract, AC mainly acts via M3 receptors again. It causes the smooth muscle in your airways to contract.
Bronchoconstriction.
Right, narrowing the airways. It also stimulates glands to produce more mucus. And it can stimulate little sensors called chemoreceptors in your major arteries that monitor oxygen and CO2 levels.
So it's pretty clear why drugs that block these muscarinic effects would be good for things like asthma or COPD.
Exactly, want to open those airways up.
Okay. Moving down the urinary tract, bladder function.
Yep. The parasympathetic system generally promotes bladder emptying. So ACC, mostly through M3 receptors, again, maybe some M2 contribution, makes the main bladder muscle, the detrusor, contract.
Increases pressure, makes you need to go.
Right. Increases voiding pressure. But again, if you just give systemic ADA, you probably wouldn't see a huge effect on urination because it doesn't get there well enough and breaks down too quickly.
Same story for the gut, the GI tract, I guess. Vagus nerve uses ACD to simulate digestion.
Exactly the same principle.
Yeah.
M3 receptors are key for controlling gut muscle movement and secretions, with M2 helping out. Right. Stimulating the vagus nerve increases motility, contraction strength, and secretions like acid.
But taking an AC pill wouldn't help in digestion.
No, the systemic effects are just too inconsistent and short-lived for that kind of therapy.
What about glands? Saliva, tears, sweat? I know dry mouth is a big side effect for some drugs.
Yes, AC is a major stimulator for many glands. Lacrimal glands for tears, nasopharyngeal glands in your nose and throat, salivary glands, sweat glands.
It's all stimulated by ASO.
Primarily through M3 receptors, though M1 ships in for saliva production too. This is why blocking these receptors causes dryness.
And the eye. You mentioned pupil effects earlier, things like belladonna making pupils bigger.
Right, in the eye, HA acts mainly on M3 receptors to constrict the pupil, that's meiosis. It does this by contracting the sphincter muscle in the iris.
Makes the pupil smaller.
Yep. And it's also essential for focusing on near objects. It contracts the ciliary muscle, which changes the lens shape. That's called accommodation.
So blocking these receptors would cause
Blurred vision, especially up close, and dilated pupils. The opposite effects.
Okay. Lastly, the brain, the CNS. You said muscarinic receptors are there too. What's aceria doing up there?
Well, ACEs itself doesn't easily get into the brain from the bloodstream, but drugs that mimic ACE and can cross the blood-brain barrier often cause a general arousal or activation.
Wakes things up.
Sort of. And research strongly suggests these CNS muscarinic receptors are vital for learning, memory, cognition in general, controlling movement, regulating appetite, even how we perceive pain. Lots of important functions.
Okay, got a good picture of what AC does now. Let's switch to the drugs that mimic it, the muscarinic agonists. What are the main types we use?
We can basically split them into two main chemical families. First, you have the cholinesters.
Like ACE itself?
Yes, ACE is one, but also synthetic ones like methacholine, carbachol, and bethanechol. They're all structurally similar to ACE.
Okay, cholinesters. And the second group?
The second group is the naturally occurring alkaloids, things found in plants or fungi like pilocarpine, muscarine, arecoline.
Right.
And then synthetic drugs based on these natural structures like civime-line.
And agonists, they basically turn the receptors on, right, producing similar effects to ACE, maybe more selective or longer lasting.
That's the idea. Let's look at specifics. Acetylcholine itself, we know, breaks down super fast, limited use, but you can use it topically in the eye, like during surgery, to constrict the pupil, cause meiosis.
Okay. What about methacholine? I think I've heard of that being used for diagnosis.
Yes, exactly. Methacholine is broken down slower than ACE, and it mainly hits muscarinic receptors. It's given by inhalation in a test for bronchial hyperreactivity.
For asthma.
Often used if asthma is suspected, yeah. People with asthma tend to react strongly. Their airways constrict even with low doses. But you have to be careful, there are contraindications.
Like what?
Things like severe existing airway problems, recent heart attack or stroke, uncontrolled high blood pressure, pregnancy. You wouldn't want to provoke a severe asthma attack.
Right, makes sense. And bethanechol. You said that one targets the bladder and gut more?
That's its main niche, yeah. Bethanechol resists breakdown and is mostly muscarinic. It's used mainly for urinary retention when there's no blockage, just helping the bladder muscle contract.
To help people pee.
Basically, yes.
Yeah.
And sometimes to get the gut moving after surgery, though less common now, usually best taken on an empty stomach to avoid nausea.
Okay. Carbachol. Another cholinester.
Carbachol also resists breakdown, but unlike bethanechol, it also activates nicotinic receptors quite a bit, not just muscarinic.
So broader action.
A bit broader, yes. Its main uses are topical in the eye, for glaucoma to lower eye pressure and also to cause meiosis during surgery. Got it. Now the natural alkaloids. Pilocarpine seems pretty common.
Pilocarpine is interesting. It's technically a partial agonist. It doesn't give the absolute maximal response even when bound. And sweat glands are unusually sensitive to it. Yeah. So clinically, it's used for dry mouth xerostomia caused by things like radiation therapy or Sjogren's syndrome.
Autoimmune disease?
Right. Affects moisture glands. Pilocarpine helps stimulate saliva. It's also used topically for glaucoma and meiosis. But a really common side effect is...
Wetting.
Exactly. Increased sweating.
It's civime-line. Also for dry mouth. How's it different?
Civime-line seems to prefer M1 and M3 receptors, which are abundant on salivary and tear glands. It promotes salivation quite effectively, lasts a while.
So it's a silagogue.
Right. And some studies suggest it might have fewer side effects or be tolerated better than pilocarpine for dry mouth, maybe a bit more targeted.
Okay. So with all these agonists stepping on the muscarinic gas pedal, what are the general red flags? Contraindications, side effects? Well, since they mimic the rest and digest system, the warnings follow logically. You'd avoid them in people with asthma or COPD, risk of bronchoconstriction.
Makes sense.
Also avoid if there's a physical blockage in the gut or urinary tract. Don't want to push against the wall. Active peptic ulcers are bad too. and conditions like severe bradycardia or low blood pressure, because these drugs can worsen that.
Okay.
Hyperthyroidism is another one, might increase the risk of atrial fibrillation. And common side effects are just exaggerations of parasympathetic activity, sweating, diarrhea, cramps, feeling like you need to pee urgently, blurry vision from pupil constriction, maybe low blood pressure.
Well, what if someone takes too much? Overdoses?
Overdoses, maybe from eating certain mushrooms or plants, just looks like extreme parasympathetic stimulation.
Yeah.
All those effects ramped way up.
How do you treat that?
The main antidote is atropine. It's a muscarinic antagonist. It blocks the receptors, and it can get into the brain, which is important. Plus, lots of supportive care help with breathing, managing heart function, dealing with any fluid in the lungs.
Okay, atropine is the key there. So we've covered the agonists. Let's flip to the other side. The muscarinic antagonists. The brakes. What kinds are there?
We can group these into maybe three main categories. First, the classic natural alkaloids, atropine and scopolamine, used for ages.
Okay.
Second, semi-synthetic derivatives. These are based on the natural ones, but chemically tweaked. Things like homatropine, tropicamide for eyes, or the inhaled drugs like ipratropium, tiotropium, aclidinium, meclidinium for lungs.
Right, the COPD drugs.
Exactly. And third, purely synthetic ones. These are totally man-made, and some try to be a bit more selective for certain subtypes like pirenzepine or darafenocin and solifenocin for the bladder.
And these antagonists, they just sit on the receptor and block ASHA from binding, stop it from being activated.
That's the main idea, yes.
Yeah.
They block HC at muscarinic sites. They generally don't mess with nicotinic receptors much, though some types, the quaternary ammonium ones, might have a little bit of nicotinic blocking activity.
You mentioned something earlier about paradoxical responses. That seems odd for a blocker.
Yeah, it's a neat wrinkle. Turns out there are also muscarinic receptors on the nerve endings that release ACAW, presynaptic receptors.
Okay.
And often, these act like a feedback brake. When ACAW activates them, it tells the nerve to release less ACAW. So if you block these presynaptic brake receptors with an antagonist,
You might actually get more ACAW release.
Exactly, in some situations. And that extra ACAW might then compete with the antagonist at the main target cell receptors, leading to effects that aren't straightforward blocking. Complex feedback loops.
Biology is never simple. Okay, now it seems like different parts of the body react differently to these blockers. Low doses affect saliva, higher doses affect the heart and eyes, even higher for the gut. Why is that?
That's really key for understanding side effects. Low doses of atropine, for instance, are pretty good at drying up saliva, bronchial secretions, sweat. You need more to dilate the pupils, paralyze eye focusing, speed up the heart.
And even more for the bladder and gut.
All right, slowing down the bladder and GI tract takes higher doses. Inhibiting stomach acid secretion often takes the highest doses. And interestingly, it's not really because atropine binds better to receptors in the salivary glands than the stomach atropine isn't very subtype selective.
So what causes the difference then?
It's likely a mix of things.
Yeah.
How much that organ relies on constant parasympathetic input, its tone, maybe the number of spare receptors, local reflexes, other control systems kicking in. It's about the overall functional importance of cholinergic signaling in that specific tissue.
So organs that heavily depend on ASHI signaling show effects at lower doses of blockers.
That seems to be the case. Now let's touch on some specific antagonists. Atropine is the classic prototype.
Right.
Speeds up heart rate, dry secretions, dilates pupils, paralyzes focusing, slows the gut, can make urination difficult, doesn't usually affect blood pressure much on its own. And crucially, it's the antidote for poisoning by H-mimicking drugs or nerve agents.
Okay. And scopolamine. Similar, but
Yeah.
known for motion sickness.
Correct. Scopolamine has similar peripheral effects to atropine, but it gets into the brain more readily and has stronger CNS effects.
Like,
Drowsiness, amnesia, fatigue. That's why it works for motion sickness, often as a patch behind the ear.
what about homatropine, tropicamide, cyclopentolate? Sounds like eye drops.
Exactly. They're shorter acting than atropine. Used in ophthalmology to dilate the pupil mydriasis for exams and paralyze focusing cycloplegia for measuring eyeglass prescriptions. Shorter action means vision returns to normal faster.
Good for the patient.
Mm-hmm.
Then the inhaled ones, ipratropium, tiotropium, etc., for COPD mainly.
Yes. These are quaternary amines, meaning they carry a charge and don't get absorbed well systemically when inhaled.
So they stay in the lungs mostly.
Right, which minimizes side effects elsewhere. Great for relaxing airway smooth muscle, causing bronchodilation in COPD. Ipratropium can also be used as a nasal spray for runny nose, rhinorrhea. Aclidinium and meclidinium are newer, longer-acting versions for COPD maintenance.
Pirenzepine and tilenzepine, M1 selective. Were they ever big?
Pirenzepine was developed to try and selectively block M1 receptors in the stomach, reduce acid for peptic ulcers, hopefully with fewer side effects than atropine.
Did it work?
It showed some promise, but wasn't huge in the U.S., and then much better drugs came along, like H2 blockers and proton pump inhibitors, so it's not really used much now.
Yeah.
Olanzapine is similar.
Okay. Then there's a whole bunch for overactive bladder, right? Oxybutynin, tolterodine.
Yes, a big category. Oxybutynin, trospium, darafenacin, sulfafinacin, tolterodine, fesoterodine, all muscarinic antagonists used for OAB symptoms, urgency, frequency, incontinence.
How do they work?
They block muscarinic receptors, mainly M3, in the bladder wall. This reduces those unwanted contractions. Some, like trospium and other quaternary amine or darafenacin and sulfafinacin, which have some M3 selectivity, might have fewer CNS side effects like confusion, which is good, especially for older people.
And fesoterodine.
As a prodrug, it gets converted in the body to tolterodine, the active drug, which also seems to prefer the bladder receptors somewhat.
Glycopyrrolate. Another one.
Glycopyrrolate is also a quaternary amine, so less CNS entry. It's used sometimes for peptic ulcers, though again, less common now, and also to reduce excessive salivation, sialorrhea.
Okay. And lastly, dicyclamin hyoscyamine for IBS and trihexyphenidyl-benztropine for Parkinson's.
Right. Dicyclamin and hyoscyamine are sometimes used for diarrhea-predominant IBS, trying to calm the gut spasms.
Yeah.
But evidence for long-term benefit is limited, and they cause anticholinergic side effects, including constipation, ironically.
Yeah.
Trihexyphenidyl and benztropine are used in Parkinson's to help with tremor and rigidity by blocking brain cholinergic activity. But because of significant side effects, especially cognitive ones, they're generally avoided in the elderly or those with dementia.
So just like the agonists, these antagonists have their own list of cautions and side effects.
Absolutely. Very predictable consequences of blocking the parasympathetic system. Dry mouth, constipation, blurred vision, indigestion, thinking problems or confusion, trouble urinating, especially if you have an enlarged prostate.
VPH, yeah.
Right. Risk of GI obstruction, and potentially triggering angle closure glaucoma in people who are susceptible.
And overdose. Atropine poisoning, what does that look like?
There's a famous mnemonic for atropine poisoning. Red as a beet, dry as a bone, blind as a bat, hot as a firestone, and mad as a hatter.
Wow, okay. So flushed skin.
Flushed skin, very dry mouth and skin, no sweating, dilated pupils causing blurred vision, high fever, and altered mental state, confusion, agitation, delirium.
How do you sheet that?
First, stop any more drug from being absorbed. For severe cases, you might use physostigmine.
What's that?
It's an anticholinesterase. It boosts AGEs levels, helping to overcome the blockade, but it has its own risks, so it's used carefully. Otherwise, manage agitation with benzodiazepines and provide supportive care breathing support, cooling for the fever.
And kids are more sensitive.
Yes, children and infants can be particularly susceptible. And you always have to consider interactions if someone is taking multiple drugs with anticholinergic effects, like some antipsychotics or antihistamines. The effects can add up.
Well, this has certainly been a deep dive. We've really unpacked muscarinic receptors, SCX, and all of these drugs. So to kind of wrap up the key points. These receptors are crucial everywhere, involved in so many functions.
Absolutely fundamental.
And drugs targeting them are therapeutically important, but because the receptors are so widespread, side effects are a major challenge.
Always a balancing act.
The really exciting stuff seems to be the push for more selective drugs, those allosteric modulators, the bitopic ligands. They hold promise for more targeted treatment with fewer unwanted effects down the line.
That's a great summary. The progress in understanding these receptors at a molecular level and developing these smarter drugs, it really is paving the way for better therapies.
And just to leave you with something to think about, given how complex and widespread this whole cholinergic system is, what other, maybe unexpected therapeutic avenues might open up as we get even better at understanding the differences between subtypes and how to tweak them with things like allosteric modulators? Could we see highly specific treatments for conditions we currently struggle with or that need really broad interventions right now? Something to consider. Thanks for joining us for this deep dive.